Hello everyone, and welcome to From Shipman to Mid-Staffs, Does Doctor Still Know Best? My name is Rob Walsh, I'm a medical student and I'm one of the organisers of the Sheffield Salon, and I'm chairing today's debate. And this debate is one in a strand looking at institutions in crisis and is brought to you in association with the Health Service Journal. On the surface, medicine might not be facing the obvious disasters that seem to be afflicting other professions and institutions. According to the government, doctors have been put in the driving seat of the NHS, whilst they retain a level of public trust that most lawyers and journalists would give an arm for. But many of those in the profession are feeling less confident about their position. The Health and Social Care Act was forced through in the face of considerable professional opposition, and guidelines, targets and other changes to training and working hours have altered the old ways that the medicine worked. 85% of GPs think their specialty is in crisis, and many throughout the profession are dropping out or retiring early. Meanwhile, whilst nursing has taken more of the heat than medicine in the aftermath of the mid-staff scandal, it comes at the end of a long line of similar failures, whether Alder Hey, the Bristol Heart scandal or Harold Shipman. The GMC recently stated that complainants about doctors had doubled in the last 5 years. More deeply, there is a question as to what the doctor's role ought to be today. The scope of the profession has extended into areas of social policy such as smoking bans and alcohol prices, but at the same time, patients' power seems to be increasing in the clinic. The government is promoting an increased role for expert patients, not just in managing their own conditions, but even becoming involved in commissioning services. So what is the role of the traditional expertise of the doctor in the 21st century? It's a profession in crisis. To debate these issues, we have a top-notch panel who'll be speaking in the order that I'll introduce them. So first we'll have Hamish Meldrum, who's one of the UK's leading medical leaders of recent years, having last year completed his 5-year term as Chairman of Council for the BMA, and having previously worked as a GP in East Yorkshire for 30 years. Secondly, we have Claire Gerarda, who's Chair of Council of the Royal College of General Practitioners. She's well known as one of the leading critics of the Health and Social Care Bill and has practiced as a GP for more than 20 years. I believe you'll be stepping down shortly as well, so hopefully we can get both her and Hamish to say something controversial. Next we'll have Frankie Anderson, who's a hospital medicine trainee, currently studying for a Masters in Neuroscience at the Institute of Psychiatry in London. She was also previously one of my co-conspirators in organising the Sheffield Salon. And then finally we have Christina Patterson, who is a writer, broadcaster and columnist, who after experiences of very poor care in the NHS began writing about healthcare issues. This has included a special report on nursing for The Independent, which was nominated for this year's Orwell Prize. So Hamish, would you like to kick us off?
Yeah, well, thanks, Rob, and good afternoon, ladies and gentlemen. I mean, I've actually got a little bit of a problem with the title, because I'm not sure the doctor ever did know best. This one certainly didn't. And as for Harold Shipman, well, he was a serial killer who hid behind his role as a doctor to carry out his crimes. And Mid-Staffs was a grotesque collective failure on the part of managers, doctors, nurses and regulators, leading to dreadful and a shameful catalogue of disasters for patients. Now, of course, we can't and we mustn't ignore these extreme examples of criminality and system failure, but neither should we act as though this is the norm in the NHS. So in the brief time I have, I want to try and give you some perspective of where I believe we are now, some idea of the problems that we face, and if I can, give you some idea of how we might address them. Doctoring has moved a long way from the days of Sir Lancelot Spratt in Doctor in the House and Dr. Finlay and his famous casebook, yet some look back on these days as a golden age of medicine. It may be that then many doctors did think that they knew best, and many patients may have seemed happy to go along with this. Life may also have seemed simpler, but life was shorter, unhealthier, and medicine was often powerless to deal with many of the conditions that it was presented with. Today we obviously have new challenges: an ageing population, burgeoning lifestyle problems, expensive medical developments, an understandably more demanding public, and a much more sceptical and questioning media. And all this in the context of an increasingly tightening budget. Couple these with a changing medical and nursing workforce who have different work-life balance expectations compared to their predecessors, not something that just applies to medicine, and you could have a potential recipe for disaster. Read the pages of The Sun, The Express, and certainly the Daily Mail, and you might believe that the NHS is indeed in crisis, and that doctors are a bunch of grossly overpaid, lazy incompetents who time and time again are either killing or jumping into bed with their patients. However, read the latest reports from the Commonwealth Fund and Mori, and they tell you that the UK still has, not quite the best, but certainly one of the most cost-effective healthcare systems, and that doctors remain far and away the most trusted of all the professions. So, where does the truth lie? Well, obviously somewhere in between, though without wishing to sound complacent, I believe it's rather closer to the Commonwealth Fund and Murray than it is to the Daily Mail. But we can't pretend that there's nothing that we should do, nothing that we can do, in fact, nothing that we must do. So at the risk of actually sounding like a doctor who thinks he knows best, here's my prescription for some of the things that need to happen if we're to have a healthcare system that is fit for purpose for the next 20 or 30 years, rather curiously the time I'm likely to need it most. First, improve the selection and training of nurses and doctors, nursing and medical students. Most of them are great people, but I feel in many ways the system is shortchanging them, and in that sense it's also shortchanging patients. Next, cultivate a much more open culture, where criticism and feedback from patients, staff and the public are valued, not feared. One of the problems with mid-staffs was a failure, even a fear, to speak out when things palpably were going very wrong. That culture must change. Third, nationally institute a debate amongst the public, staff and politicians about what they really want from the NHS and what they're prepared to pay for it, remembering that the UK's healthcare system is still one of the cheapest in the developed world. And whilst I'm happy that in tandem with that discussion we also debate how to pay for our healthcare, either through general taxation, social insurance or privately, let's just remember that one way or the other, it's you and me that pays for the healthcare system. And I still believe that the fairest way, the simplest way and the most cost-effective way is to do that from general taxation. Next, and this is really important, at a local level, really engage with patients and the public. And this can't be a one-off. It has to be on an ongoing basis. Engage with them about how to provide the best possible care to their localities, accepting that whilst there are many things that can and should be provided in or closer to the home, for other more specialised services, it may mean closing certain well-loved local facilities and having to travel quite a bit further. Next, put an absolute ban on any major system reorganisation for at least the next decade, if not the next 2. I must have seen 5 or 6 in my career, and I've yet to see one where the outcomes justified the disturbance and cost of the changes. Lastly, promote integration, not competition, because there's not a lot of evidence that competition really works in the NHS, certainly in the current system. And especially promote the integration of health and social care, not through a major structural reorganisation, but by introducing sensible ways of working, such as has been successfully done in Torbay and Devon. In an increasingly complex, cash-strapped world, doctoring and the provision of healthcare needs to be much more of a partnership in the consulting room between doctors, nurses, patients and carers, and a partnership at local and national level between public, patients, the professions and politicians. And of course we can talk about changes to contracts, to working hours and to regulation. But if we don't get the fundamental principles right, then we'll be wasting our time. Healthcare has changed and needs to continue to change, and change very significantly. But to those who would argue that the social solidarity model of healthcare that we've had in this country for the past 65 years is no longer appropriate in a modern, consumerist-led world, I profoundly disagree, and we contend that it's never been more important or more necessary if we're to face up to the huge challenges of the coming years. Thank you.
Okay, thanks a lot, Hamish.
Thank you.
Claire.
I want to tackle this really from the role of the doctor, so I actually agree with most of what Hamish said. I became a doctor because I was inspired by watching my father at work. He was a single-handed GP, and he taught me that medicine was a vocation, and that to be a good doctor, you had to give something back to your community. And he taught me that time, sympathy, and understanding must be lavishly dispensed, but the reward will be found then in the personal bond which forms between you and our patients. Not in a power relationship, but in a relationship. Across the world, we're facing something of a crisis in medicine, with doctors under increasing pressure to focus on the disease rather than on the patient, on the science rather than on the caring. And this is causing patients to become mistrustful of us. In this increasingly marketised, commercialised health service and its focus on choice and competition, where patients become consumers, doctors risk becoming little more than providers of goods, or as Foucault describes, almost mechanised intermediaries between the pharmaceutical industry and client demand. That is, simple distributors of medicine and medication. And in doing so, empowering the patient to make choices about what they want and what they need. So choice. Giving patients choice gives them more freedom to choose their healthcare. And it sounds like a good idea, doesn't it? After all, choice, like freedom, is a good thing by definition. And this view is increasingly seen as established wisdom in health policy, with choice being seen as an indisputable good thing. The logical consequence of this is that a high-quality therapeutic relationship is one that supports autonomous choice by the patient, where the patient and the doctor are equal players. Not necessarily. The American psychologist Barry Schwartz wonders if the disbenefits of choice outweigh the benefits. His work suggests that too much choice can be a bad thing. It has two negative effects. The first is that it produces paralysis rather than liberation, because with so many things to choose from, people find it very difficult to choose at all. And the second is, even if we overcome that paralysis and make the choice, we end up less satisfied than if we'd had fewer choices in the first place. Schwartz found that the more options people are given, the greater their anxiety, the greater their dissatisfaction, and the greater the disappointment they are likely to experience. Do we really want to be offered choices like this in our healthcare? And are the choices we make meaningful when we lack specialist knowledge? Schwartz says, it's no longer the case in the US that you go to the doctor and he tells you what to do. Now you go to the doctor and the doc tells you, well, you can do A or you can do B. A has these benefits and risks, B has these benefits and risks. What do you want to do? And you say, Doc, what should I do? And the doc says, well, A has these benefits and risks, and B has these benefits and risks. What do you want to do? And you say, if you were me, Doc, what would you do? And the doctor says, but I'm not you. We call this patient autonomy, which makes it sound like a good thing. But what it really is shifting the burden of responsibility for decision-making from someone who knows something, namely the doctor, to someone who knows nothing and is almost certainly sick and hence not in the best shape to make decisions, namely the patient. In our drive to produce equality between the doctor and the patient, we mustn't lose sight of the trusting relationship between the doctor and the patient, a precious relationship which is at the beating heart of good general practice, which is what I am. We shouldn't be worrying about whether doctor knows best, but whether what the doctor knows is the best. Thank you very much.
Thank you, Claire. Frankie.
My parents regularly ring me to ask if I've seen junior doctors, your life in their hands. For those who don't know about this, it seems to involve young, attractive, well-groomed junior doctors wandering around hospital wards, being followed by multiple consultants and registrar support, while they push drips into unsuspecting patients and deal with the emotional burden of starting work. Now, this week, there's another medical programme called Trust Me, I'm a Doctor with Michael Mosley. This plethora of medical programmes on TV got me thinking. Well, specifically, the titles got me thinking, because they both have a strongly ironic tone. Clearly, the public and no one else believes this anymore. There's been a significant change in what is to be a doctor in the recent years, as my colleagues have alluded to. The cliché of the white-coated male professional wandering around wards has been replaced not only in the public's perception, but also within the medical profession. Doctors are no longer prepared to dedicate themselves completely to the job. The increasing feminisation of medicine and the drive for part-time work from both male and female doctors has made the elusive life-work balance more tangible. Nor are they prepared to work long hours for the sake of their patients. With the introduction of the working time regulations for junior doctors in 2009, limited time on the wards to 48 hours per week. Neither are they staying within medicine. A recent report from the Medical Programmes Board suggested 23% of Year 2 foundation doctors had simply not applied for higher training, with a BMA survey of 3,800 doctors demonstrating that 2/5 of them considered leaving the profession, with half saying they would not recommend a career in medicine. Hardly a vote of confidence from its own profession. But it's not just how long and how much doctors are prepared to spend in medicine. There's a marked change in public attitude to what medicine is also. The reasons are many, and include in particular that patient expectations have changed. Patients have become more internet savvy and are better able to negotiate the complex healthcare systems, and are less trusting and more sceptical of doctors. The promotion of and adoption of the patient as consumer and no decision about me without me mantra has changed patients' perceptions of what they feel entitled to from the healthcare system. Vocal and empowered patient representatives demand flexible opening hours and take control by choose and book for hospital appointments. Patients, service users, consumers, or people, as I was patronisingly informed to call these previously named patients at a recent conference I attended, are being encouraged to self-manage with personal treatment plans and personalised budgets. And they are told that they are experts in their own care. This, you may well argue, is not necessarily a bad thing in light of the catalogue of health-related disasters ranging from Alderhay to Bristol to mid-staff, which show doctors in poor light. Rather than being patient advocates, doctors came across as arrogant and self-interested. And now, in a world where transparency is increasingly being demanded, the closed door of the GP room is for suspicion, not respect. The government, too, is keen to use the demands of an articulate minority in the form of, say, HealthLink or self-styled representative organisations, Patient Association being an example, as a battering ram to push forward a consumerist understanding of healthcare. But alongside this rise in patient power, there's also been a change in how doctors view themselves. The profession has lost confidence, has been unable to stand up for itself. The highly successful campaign led by the Daily Mail against the Liverpool Care Pathway for the treatment of dying patients resulted in the bizarre affair of the Palliative Care Association initially calling for a review into its own guidelines before later demanding its own practice. Likewise, the muted and confused initial response to the MMR panic demonstrated a real lack of belief in medicine, science and leadership, and self-regulation, the hallmark of a profession, disappeared when the government made the GMC answerable to one of its own bodies in 2001. Whilst one definition of a doctor, that of the expert clinician with a mission to cure the sick, is on its way out, there's been perhaps a paradoxical rise in another role, the doctor's health evangelist. This has extended their role in a far from positive way. Now that the average GP is expected to take on multiple roles in their practice, ranging from quaffing the patient to interrogating them about their lifestyle choices and advising them on smoking cessation, alcohol reduction and exercise programs, patient weaknesses as opposed to resilience exploited in concerns about emotional well-being, while their relationships are scrutinised on the interest of identifying such substances as domestic violence. These changes of focus removes doctors' professional autonomy in rather speedy time chunks, leaving many patients dissatisfied, having to make further appointments to have the issues that they initially went about addressed. And this is not a problem just within GP. As a junior doctor, I am encouraged to be an agent for change, a game changer, or indeed, to quote Ruth Keough, Medical Director of the NHS in England, junior doctors and specialist trainings will not just be seen as clinical leaders of tomorrow, but clinical leaders of today. Time spent auditing, clinical governancing and learning to be a manager left one rather astute commentator on Twitter wondering if junior doctors are more bothered about being the leaders of tomorrow than the doctors of today. Nor is this solely a problem with medicine. The broadening roles of teachers now ask them to act as parents, police officers as social workers, and universities as social levellers, leaving everyone to do everyone else's job. So does doctors still know best? In the area of medicine, rather than health evangelism, I would say yes. I would also argue that the role of the expert needs to be defended, but equating the job to one in John Lewis, as Norman Lamb did this week, sells short those that matters most, the patients.
Thank you very much, Frankie. Oh yeah, just a quick thing. What's QOF? You mentioned
Sorry,
quaffing.
Quality and outcome framework.
What's that?
It's how we're paid.
It's the system to incentivise GPs to do certain tasks on diabetes, hypertension.
I thought that was called their salary.
No, it removes 20% of our income and gives it back in performance-rated pay, and we can never get 100%. So it's actually how we get a pay drop.
Anyway, we can
started a discussion.
we can discuss that later.
It's a case in point. It's a pejorative thing to.
But anyway, Christina, if you'd like to give your introduction.
I was getting worried because I thought there was a very, very worrying consensus on this panel, and this is supposed to be a battle, and I don't know how we're going to battle, but we'll do our best.
Yeah.
On Wednesday, I took part in a panel called Trust Me, I'm a Journalist. As you might guess, it was about the ethics of journalism. Journalists aren't exactly held in high esteem at the moment, but then they never were. We've always battled with politicians in being the profession or trade that people trust least. Doctors, on the other hand, have had it easy. Mothers want you to marry them. My mother's still heartbroken that I didn't. People stand up a bit straighter when they meet a doctor. They might even suck their tummy in. They still think that being a doctor is a proper grown-up thing to do. And then there's the money. Sorry, but there's the money. It was Anand Bevan who said when he started the NHS that he did it by stuffing their mouths with gold. Well, that was nothing compared to what happened under New Labour. I know doctors don't like these figures being quoted, but according to the BMA, the average salary of a GP in practice is £103,000. No wonder when my former boss, who'd been on Fleet Street for 40 years, went to see his doctor, he managed to piss him off. The doctor asked what he could do for him, and he asked him for a loan. Doctors are still the most trusted profession. 9 out of 10 people trust them, according to, I think, Ipsos Mori, but loads of other polls as well. But things are changing for pretty much every profession at the moment. And they're changing in medicine too. Doctors don't work, as many number of people on the panel have pointed out. They don't work the hours they used to. This is partly to do with EU directives and partly to do with the way GP practices are now structured and run. And this is much nicer for doctors. They do less work for more money. The idea of the family doctor, however, who would come and see you in the middle of the night now seems like something out of Downton Abbey. And I don't think it's quite so good for patients. Medicine is being profoundly affected by many of the changes in what we might call modern life. There are all the clinical advances, of course, and all the complicated possibilities thrown up by what we might call the personalisation of treatment. But it's also being affected, as everyone is being affected, by the digital revolution. Now, I think it would have been quite interesting to have been alive in Renaissance Florence, and I think it would have been quite interesting to have been alive during the Industrial Revolution. But these are nothing compared to what we're living through now. The internet is wiping out whole industries. Journalism, for example, is on its knees. It won't wipe out medicine, not least because sitting in front of a screen all day is one of the unhealthiest things anyone can do. But the fact that we're all bobbing around on an ocean of information does mean that we all think we're experts now. And that, as others have pointed out on this panel, isn't always great for doctors. The old model was paternalistic. You were probably a bit scared of your doctor and very polite to them, and you didn't want to trouble them unless you were practically dead. The new model's a bit different. You might well see a different person every time you go to the surgery. By the time you get there, you might feel it would have been easier to get on the X Factor. You probably had to take time off work to be there. You may have been told you can only talk about one ailment at a time. But you're going to wrest some power back. You're clutching a big sheaf of papers you've printed out from Google. Actually, I'm not sure that access to Google really amounts to patient power. 10 years ago, when I was diagnosed with breast cancer, I didn't feel very powerful at all. And this, by the way, was after 6 years of Labour spending, when the NHS was awash with cash. The bureaucracy was a joke. Everything got lost. At one point, when my surgeon was about to do a second operation and he opened up an envelope which was meant to be a mammogram, it turned out to be an X-ray of an ankle. We never found out whether it was my ankle or if it was somebody else's. That certainly wasn't the fault of the doctors. But I found a number of the doctors I came across pretty arrogant and pretty uncaring. One plastic surgeon who I was talking to about possible mastectomy and reconstruction said he thought my approach to it all was a bit heavy. I said to him I wasn't sure how light-hearted he'd be if someone was going to chop off and reconstruct his balls. 4 years ago, when my cancer came back, I was able to go to a different hospital under something called patient choice. Now, I was very glad to have this option because at the first hospital, 5 of the 6 appointments that had been made to me, it turned out hadn't been made for me. So, frankly, I didn't want to go near that place again. Now, the new hospital, it's a very, very good hospital. It's one of the best hospitals in Europe, in fact. And I did, unfortunately, have nightmares with the nursing. I didn't think I would. I thought it was going to be great, but I did have nightmares with the nursing. And as Rob said, I've written and talked quite extensively about that, so I won't go on about that now. But the doctors were great. And the plastic surgeon who did my reconstruction came in on his day off after the operation, and then when I got an infection in the reconstruction, he came in again on his day off. It might be unfair, but that him going beyond the call of duty made all the difference to my experience. And I think patients really do need to feel that doctors are going beyond the call of duty. In fact, I think they need, as Claire said, to feel that this is a vocation. In spite of all the advances in modern medicine, we're not getting healthier. More than a quarter of adults in this country, for example, are obese. Another 41% of men are overweight and 33% of women. This might sound like a joke, but it really isn't. I've been doing a piece on intergenerational unemployment for the Sunday Times magazine, and I went to interview a family in Wales. They were all enormous, and the list of ailments just went on forever: diabetes, angina, back pain, etc. One woman had even had her leg cut off through diabetes. Now, Claire and Hamish will know that it's not at all easy to address these things, but surely the answer has got to be a relationship with a doctor who you know, a relationship of trust. I don't have a problem with doctors as health evangelists. I think that's what they ought to be. If doctors can't lecture us about our lifestyle and what makes us ill, then who can? Being a doctor may still be a challenging job, but doctors can rest easy. They're in one of the very few growth industries. They should spend their really rather well-paid working lives doing their best to make it shrink.
Okay, thank you very much, Christina. Okay, before we throw it open to the audience, I've got a couple of questions that I'm going to ask the panellists to see if we can get some discussion going. So, Frankie, my first question for you is, Do you think that there's a danger that you're essentially being a bit of a paternalist, that you're setting up a kind of traditional 19th century view of what a doctor is, and that you're trying to defend your area of expertise?
Do you want me to answer?
Yeah,
now?
yeah, you can do.
Am I being a paternalist? I think at the heart of any doctor interaction is, as Claire said, a concept of autonomy. But there is also a concept that there is not quite the equation of knowledge between that doctor and that patient. And I don't think that's being paternalist to underline that point. I would also argue that where paternalism is coming into the fore is in lifestyle advice, and the concept of getting patients involved as co-producers in commissioning. I think that is more undermining that relationship and being more paternalistic than actually trying to re-embody the ideas of professionalism.
Okay, all right. Claire, do you want to come back on anything in particular? Or?
Well, I absolutely agree. I think the nudge agenda, which means every time I see any of you, I have to address your smoking, your exercise, your weight, and basically how often you have sex with your husband or wife or partner. Don't, but more or less. It's not something I think that I should be doing unless it's something you bring or it's something that's relevant. And I think the example you gave of the intergenerational Welsh family is a disgrace to our social system, not a disgrace to doctors. Doctors can't cure that. That is a marmot, health inequalities, it's intergenerational. And actually I worry that a highly intelligent, highly experienced journalist is even thinking that is something that a doctor can do. It may have been in the past when you had doctors in the mining areas who worked with local government to trying to address it through housing, through education, through schools. I absolutely agree with that. But the idea that I can give people a home, a job, I have to be there to help and to support them. And just the other issue, I am not apologetic that I earn a good income. I'm a highly trained, highly skilled professional. I do more, and GPs in this country do more than any other GP in the world. We do more to a greater degree of complexity. And actually for well paid, so be it. We make the NHS cheap without the skills of the GPs. And again, the issue about GPs is that somehow the public don't think we should be paid. There is no question that hospital doctors are paid more than that once they get bits and pieces topped up and everything. But the idea that a GP should be paid, it's like, for example, you pay, how dare a priest be paid? It's that sort of association. So I would like to say, I don't mind, and you mentioned it so many times, it's obviously an issue. Because actually, if we're going to move this debate on where I sit, GPs and doctors, I run a sick doctor service, do not feel empowered, do not feel paternalistic. They're coming to me depressed, killing themselves, turning to drugs and alcohol, or, like you mentioned, 22% of them leaving and going to Australia or New Zealand. So if we don't address this and don't come onto this in equal terms and stop undermining the role of hard-working GPs, hard-working hospital doctors and hard-working nurses, then I'm afraid we're going to sow what we reap, which is a demoralised work, the hours that I've set within, and we're going to lose the vocation that I grew up with my father.
Okay, thanks, Claire. Hamish, I'm going to ask a slightly different question to you. Obviously, there's been a great deal of discussion around the Health and Social Care Act, and there has been some criticism in the medical profession of how the BMA how strongly the BMA opposed that act. If you could have your time again, would you do things differently around the Health and Social Care Bill? Or
certain things you would do differently. But I think the idea that a trade union, which and a professional organisation, which the BMA is both of these, could effectively bring down a government, which one would need to do, is something that I think, Christina talked about the problems we had and the after effects of what was seen as a good pay rise for doctors and the politicians wanting to get their own back year after year after that. I think if we'd done anything like bringing down the government, then we would have been fair game for decades to come. I think to some extent I may have been slightly misrepresented. We made it very clear from the beginning what our view was about the bill. I had talks with a lot of Claire's colleagues, actually before even Claire was chair of the RCGP, and there wasn't a willingness for a collective view amongst all the Royal Colleges, and in fact they basically said, that's politics, mate, we're having nothing to do with that, we are keeping our heads down. And until really the last few weeks and months of the Health and Social Care Bill, that remained the case. Claire and her college accepted. So there wasn't even a consensus amongst the medical profession on that, which was why, in a way, the BMA engaged in what was called critical engagement. Now, nobody minded the criticism. I think a lot of people minded the fact that we were even engaging at all. But I say, this is the democratically elected government of the country, like it or not, proposing certain things. And it was our duty, yes, to highlight the dangers, to try and get it changed. And we did make some changes, but not nearly enough. I accept that. Some of the analysts say if we'd all pushed a bit harder at the end, we could have got it dropped. That may or may not be the case. But I say until right at the end, I don't think there was the collective will to do that, with some notable exceptions.
Okay, and Christina, so my question to you is, as Claire's been suggesting, if a lot of these medical problems that people are facing are essentially social problems,
Yeah, they're certainly
how would you respond to
Oh, well,
that?
of course they're social problems, no question of that. No, I never said that it was doctors' sole responsibility to address them, but I think it is part of doctors' responsibility because they are the people in the community who play a major part in the health of that community. Now, it's an enormous task, and the challenges in terms of, in particular, unemployment, whole areas where people don't have anything to do. I mean, it's a gargantuan task. And of course, the odd consultation with a doctor isn't going to solve that. But do I think that doctors shouldn't be so-called health evangelists in that context? I think they should. And actually, I did meet someone locally who had grown up on one of those estates, and she had started up a local community project where people were growing vegetables and teaching people how to eat healthy. I think that's a fantastic thing to do. I think that's not just doctors' role, but I think people need to. I think we all need to make much bigger efforts to address this health issue, because it really is a time bomb. Just one other issue, just that Claire mentioned. I don't think anyone thinks GPs shouldn't be paid. What I do think is that to be paid that much for a GP in practice, that is 4 times what most of their patients will be paid, and that's a lot.
So?
Well, I don't know that you deserve 4 times more than most of the people you treat. That's a lot.
I mean, I don't want to, because Hamish is the trade union, was the trade union. I don't want to go into pay and remuneration, because then you go into what's worth and what's not. The point is that no one ever has that debate about hospital consultants, and we're on par with a hospital consultant. It's always assumed that general practitioners, and there are some issues around that, because there's, as a self-employed, there are issues that need to be taken out, so that's not equivalent. But I hear this so often, so I will now say, and I'll repeat it, I am proud that GPs did earn, because they've seen a catastrophic drop in their income, because we've been punished since Hamish got us a new contract. I'm proud that they earned a good income, because GPs in this country do more for more to a greater degree of complexity than any other GP in the world, and keep the NHS value for money.
And I'm also proud that I get paid a 20th of what Paul Dacre gets paid in the Daily Mail.
And I'd like to point out that I've got no money because I'm still a student. But I'm going to throw
And
it
I'd
out.
like to point out that all journalists are losing their jobs, and I'm one of them. So.
Come and work with us.
I'm going to throw it out to the audience.
My name's Andy. I'm one of the 20% of the doctors who dropped out after being downtrodden in A&E, finishing at 4 o'clock in the morning, being back in at 4 o'clock in the afternoon the same day, which is perfectly legal. The issue about pay, there is a discrepancy in, say, if you're a GP working in an inner-city area. What kind of effect do you think that has? Do you think there's a class difference between the people who are accessing the service and the people who are providing it? Do you think that has an effect on the care that people are receiving?
I seem to know at least 2 or 3 people who I went to university with who now seem to be, who were studying medicine and who are now living a life of luxury in Australia and in New Zealand and working in their healthcare systems. And I was wondering, what do you think is drawing people to go and work over there? And should we be worried about all these junior doctors who are leaving the UK and moving abroad to practice medicine?
My question is to do with the relationship between the medical profession and the law, and in the situation that a doctor doesn't know best whether they're held accountable and what are the repercussions of their actions. I have 2 main points. Firstly, one regards the economic pressures on the NHS and the influence that this has on court decisions, whether doctors are, at the end of the day, let off the hook because the NHS don't have the money to pay for negligence actions, and to say that a doctor has been negligent could open the floodgates for actions against NHS doctors. The second point is regarding case law of the Belitho and Bolam cases, which, in my opinion, states that if a doctor can find another reasonable practitioner who would have acted in the same way, although it had detrimental effects, they would be classed as not negligent, and this standard seems to be less than the standard of a reasonable man in another profession. So how far do doctors have extra rights and respect just because they're doctors and sort of are brothers with the legal profession? So my point is, it seems that even if doctors don't know best, they're really not held accountable. And do you think this is a fair point, and how far do you think that doctors should be held accountable?
Okay.
Two quick questions. There's lots of conversation around trust, fantastic, rating yourselves very highly as a trusted profession. But in fairness...
rating themselves very highly.
Okay.
No.
Well,
The public
This is
rate.
Laurie.
Public rate them
The
highly.
oh, well, let me get to that.
Yeah, but you just said something that was inaccurate, so we just had to correct
Anyway,
it.
we'll let him speak
Sorry.
and then we'll...
The point being is, I don't really have anywhere else to go. So when I move house and go to and find a new GP, it's not like I've got lots of competition and I base my decision on trust. I go to the one that's nearest to me, and then I have an experience that varies. So I would just like to hear some words that you don't kind of take any complacency around how other people rate the trust that's in the profession. Sorry, the second one was, how do you rate yourselves very highly as doctors? That's great.
No,
Right.
they don't.
Anyway,
You
let him
do,
speak.
you
Let the
do,
gentleman
you do.
speak.
You said
No,
you.
they don't.
Anyway,
They say
anyway.
public rates
Okay,
them highly.
Let-
I'm
him
hearing the
speak.
words from the panel, so
Okay.
I'm not picking up data. The point being
You're
is,
just misquoting the panel.
Anyway,
how do you think
let
of
the man
yourselves?
speak.
How do you think of yourselves as business people when you're running an enterprise? And you mentioned value for money. I'd love to hear your definition of value for money.
Well, we have the cheapest
Anyway,
health service in the
we'll-
world for the best outcome. So that's value for money. What would you call value?
So we'll come back to the panel. Everyone
Right.
can throw in a quick couple of lines and then we'll come
Right.
back out to get as many points as possible.
I'll
So,
quickly deal with that
Hamish,
first.
yeah.
I mean, yeah, certainly we're not rating ourselves, and I don't think we're complacent. In most places, there is a reasonable choice of GPs, and I certainly wouldn't go to the one nearest. I'd ask around and see who people think is the best. In terms of value for money, what I was quoting was the Commonwealth Fund. One of the people that are held up and probably is the best in the Western world for providing medicine in the Netherlands. Now, the Netherlands spends nearly 4,000 euros per head on its healthcare system. We spend just under 3,000 euros per head. So, and that's why we come first in value for money. So it's not me, it's much better people knowledge than me that talk about that. Going back through them, in terms of negligence, I think doctors are more regulated than many other professions, in fact, probably including the law. We not only have the law to deal with, we have the GMC to deal with. And the GMC has come into criticism. I once said to the head of the GMC, you really got it right, you've pissed off doctors and the public at the same time, but as being too hard on doctors and not being hard enough, sorry, I'm getting that wrong, but anyway. The GMC regulates doctors, but also in terms of compensation litigation, there is no cap on that. And the Bolam principle is not just finding one other doctor who might agree with you, it's what the generality of doctors or whoever you're talking about would do in that same situation, and did you go along with that? So I don't think it's a lower standard of proof that's needed, and I don't think doctors get let off the hook. Pay discrepancy, Andy. I think there are real problems arising because what Christina quoted is what a full-time independent contractor gets. There are an increasing number of part-time salaried doctors, so it's not just the inner city versus the rural shires, it's how you're employed and what you do. Now, a lot of people want to be salaried and want to be part-time. They may be women with family commitments or men with family commitments, and that suits them. But I think there is a worry if you get control of medicine, and particularly general practice, in the hands of a decreasing number of people who are highly paid and highly influential. Lastly, doctors going to Australia and New Zealand. Well, the pay can't be that wonderful, Christina, if they're all going off to Australia and New Zealand.
Maybe they just hate the weather
And
here.
having been to certainly Australia, I mean, no doubt about it, the doctors there feel that it's not so much they're better valued, but they do have a better system and a better funded system of healthcare than we have here, with less of the bureaucracy, it seems, than we have here.
Okay, Christina?
I think it isn't all about money. And to respond to your point about is there a vast discrepancy between patients and doctors, to be honest, I don't think most patients really think about what doctors earn. I don't think that is the issue. I think it's much more to do with respect for the profession. And I think something similar has happened in both nursing and medicine, actually, which is to do with vocation. And when nursing was regarded as a vocation and was appallingly paid, it was held, ironically, in very high respect. Nurses were very well respected. They were often given free cab journeys and free theatre tickets and things like that. Because, and one nurse said to me, you know, this was the compensation for being regarded as possibly not very bright. I mean, I don't know whether that's true or not, but I think something, and yet, as they now have to have degrees and they've been not brilliantly paid but better paid, actually the fact is that respect for the profession has gone down. I think something similar has happened in medicine. I'm not exactly, obviously you'll know much more about this than I do. I'm not exactly sure what it's about. I think it's partly the sense that the public have that doctors are not as available to them as they used to be. But I also think that one thing applies to both professions, and I think it's absolutely fundamental, and Claire touched on it in what you said earlier. It's about vocation. I think people really need to feel that their health is such a sensitive area. You know, when you're about to have your breast chopped off, frankly, you need to know that the person you're doing it doesn't just feel it's a job and that the reason they do it is because they're going to get a nice fat paycheck at the end of the month. And I think if people are going to New Zealand or Australia or whatever to become doctors, I doubt it's because of the money. It's probably because there is something wrong with their perception of how they are valued, and maybe also about what they feel they can contribute. And I think that's what we really need to address.
I think the issue about Australia and New Zealand is complex. Yeah. I think it's also complex about the generation, as you talked about, the generational shift. I think your surgeon coming in, I mean, I still have the luxury of having some space in my life because I'm chair of the college. So I can have patients ringing me up on a Saturday. I can arrange to see patients in the evening and at weekends because I'm not overburdened and overwhelmed like the A&E doctor with the work, which is, I think, again, since the marketisation of our health service, where patients have become aliquots of activity that have to be put through a sausage machine, what we're losing is the essence of kindness that we can start to deliver within healthcare. And doctors and nurses want to deliver kindness, but they can't because they have a certain amount of activity they have to deliver. The resources are there, and I think the public need to understand that we all want to do that, but we can't. We cannot do it within the constraints that we're doing with a decreasing budget and with all the changes and everything else that we're doing. And also, I've just come back from China and India. If you want to see demigods, they are the doctors. They are so utterly demigods. And I think we've got to start celebrating what's happened in empowering the patient in this country. Shared decision making, no decision without me, about me, without me. And if we don't do that and instead just vilify the NHS and those that work in it, I said this in another session, we're going to walk. And we're going to walk to Australia. They'll all come back, by the way, because they'll all decide it's too hot.
Funny. I worked with Andy, so I feel slightly responsible for the fact that you've now dropped out of medicine. But I think going back to your point about Australia and your point about why 23% leave, I think there's been major changes with what a junior doctor is nowadays. The introduction of the European Working Time Directive has, which means that we now work 48 hours on a ward, has changed the firm structure. So you'll work more shifts with more people. And I think as a junior doctor, you sometimes feel that you get lost in the machine because there's no continuity in your education, there's no continuity in your patients, you're not seeing people through to the end. And actually that's very lonely, it's very miserable, and it's, you know, and I think that is one of the reasons why so many junior doctors feel dissatisfied. I think there's also been a increasing tick box attitude to postgraduate education. I think the duality of purpose of what we call work-based assessments, which are, if you put this chest drain in, suddenly you're competent at putting chest drains in, kind of is a reductionist approach to what it is to be a doctor. And actually, we get fed up with medicine. we get fed up of the, you know, if that's what medicine is, if medicine is ticking boxes, if medicine is working, you know, 8-hour shifts on a Monday, 7 hours on a Tuesday, won't see you again till a Friday, then actually why should you feel engaged with this profession? And I think, you know, that's, you know, the proletisation of medicine is one of the reasons why people are not coming back. And actually, I think it's a bloody disgrace that people are going to Australia, because it costs 250,000.
400,000.
Yeah, £400,000 just gone. But you can tell when I trained, it's gone. You know, £400,000 to train a doctor, and you know you're working in Sydney. You don't pay your student fees back because you're not in the system, and you know I think there needs to be a degree of responsibility with that. Just going back to Hamish's point on the social and health bill, I understand your point about not wanting to get involved in politics, but it doesn't stop doctors getting involved in minimum pricing or plain packaging. So we are getting involved in politics on one sector, but not in terms of the social and health bill.
To clarify, I didn't say we didn't. I said a lot of doctors didn't want to get involved. But yeah, I absolutely agree. Medicine is political, and we need to be involved.
I find myself in a bit of a paradox with this particular question about trusting doctors, because as individuals, I have friends who are doctors. I trust my own GP. When I meet individual doctors, I always like them, get on with them. They seem quite sensible. If I have a complaint about them, it's that they never seem to buy their own cigarettes. I always ponce of other people. But as a group, I fear and despise doctors, and you know the British Medical Association in particular, I find to be one of the greatest threats to freedom in this country. Claire's organisation is not so bad. It's not quite so political. I'm not just saying that because you're here. But the Royal College of Physicians have a manifesto: do this, do that. Minimum pricing he brought in. People on 6-figure salaries telling people on 4-figure salaries that they should be spending more money buying alcohol, plain packaging, display ban, the smoking ban, fizzy drink taxes. You know, just this constant wearisome wave of demanding legislation again and again and again, I feel is eroding people's faith in doctors. And I know you'll come back with Jon Snow and the Broad Street Pump, and the doctors have always campaigned for certain things. But never before have we had the medical establishment being at open war with large sections of the population, talking about refusing to treat people with certain conditions, obesity or smokers and so on. And so I accept that 90% of people have faith and trust their doctors. I accept that it's only about 9% for politicians. But if doctors are going to start behaving like politicians and demanding legislation, they can expect to see their trust fall, as happens with politicians. They really should get on with their job of patching people up, not changing the law.
And we talk about do doctors know best? I think it's probably fair to say some doctors do and some doctors don't. There are, as I think all the panel would agree, some doctors out there who have failed their profession. Mm-hmm. Some doctors at Mid Staffordshire turned the other cheek while patients were lying in their own faeces or worse. And what I'd be interested to hear about from the panel is, what do they want to see for the profession to take ownership of the failure at Mid Staffs, to take ownership of the Francis report, the recommendations there, and how they will themselves police their own profession and take it back and prevent some of the criticism that we see in the media from people like myself and Christina. I think the onus has to be on the professions, both nursing and medical, to own their failures and turn themselves around. They won't do that by saying that certain recommendations, such as a legal duty of candour, for example, which I know the BMA are opposed to, that kind of thing actually might change something. Saying that the existing professional codes will work won't actually, because it failed at Mid Staffs, it failed at Bristol and other places. So I'd be interested to see how to take the panel back actually to Mid Staff, Shipman and the failures, and how the professions can turn that around.
So my question was around, just interested in a view on, I completely agree with the point I think Hamish made at the beginning around integration rather than competition driving the way forward, and also patient choice to a point, but actually also you know more than I do about probably what's wrong with me, so I'll trust you to make that decision in terms of suggesting where I go. How do you square that with so there's a hospital or something that's running very poorly or inefficiently, and how you can encourage that to change in inefficiency if you don't have competition or you don't have patient choice?
Hi, I think one of the things that came very clear is that the conversation between the public and the profession is very is not right. It's not talking about the real issues, and there is a real them and us kind of sense that came out of the questions. And if we want, clearly the profession needs to change because medicine has to change, because expectation has changed, lifestyles have changed, and so on. So there's a lot of changes that are needed, a lot of restructuring, but actually the conversation about that is not a candid conversation. And just one point is, in the UK, national insurance contribution is something like £70 a quarter now. In Germany, for example, health insurance, you would pay about €1,000 a month. For that 70 quid, which is the minimum payment, you actually get a healthcare. And the real conversation to be had in the public is what people are willing to pay for healthcare. And that's the one conversation that's nobody having. And the conversation about mid-staff is about staffing levels. What happens to people who are under stress? So either we say that they're all evil and somehow in mid-staff all the evil nurses and doctors of the universe came together and did evil deeds, or we say something happens to people when they're under stress and somehow the profession is struggling to support them. And beyond that, in my role from an organisation which is actually, doctors have campaigned for a long time. Like doctors campaigned actually for the NHS. So they were very political doctors, and I'm actually a vice chair of an organisation that has been an organisation of political medics for 75 years or something. So it's not a new phenomenon. But just to say that the conversation needs to change and it needs to be more frank.
It felt like something that came up quite a few times along the panel was about doctors acting as like healthcare evangelists, and I want to talk about the role of like public health doctors and like global health doctors. There seems to have been a movement, well, for a long time, in that doctors working in public health, the aim is to sort of prevent illness in the first place and to make societies as a whole like healthier places to live. And that kind of, my point is that I feel it pulls in two directions. One is that I think is a sign of like a mature civilization and a sensible profession, that they recognise that medicine can't make people healthy and that we live in a society which is fairly sick, and it will take a lot more than a bunch of good doctors to remedy that problem. The thing that kind of grates for me a little bit, I'm a medical student and I'm quite interested in public health, but if this debate's about do doctors know best and do people still trust doctors and so on, one way to lose trust and to become despised is to put yourself in a position of excessive power, or to give the impression that you're making decisions about which you're not really qualified. So you now have situations where, you know, Jim Kim is a doctor who now runs World Bank. You have doctors making policy about banning smoking in public places and stuff. And I think there's just a tension, and I don't know where the balance lies between doctors having an important role in making societies better places to live, but also not imposing their will in some sort of superiority, this kind of bad stuff. So I wonder if the panel has any thoughts on where the balance should be struck.
I think what we're seeing is a reflection of the rise of medicine, but also the fall of politics as well. So in the past, where there were political decisions to be made about how we take smoking or alcohol, they were typically couched in morality terminology. Alcohol is wrong, smoking is wrong. That's gone because I think there's been quite a breakdown in what we view as politics, and that kind of breakdown of that ideology, the loss of the church, the loss of trade unions, the loss of the community has resulted in the rise of kind of the evidence says approach to kind of political, what should be political decisions rather than healthcare decisions, which I think reflects back on the gentleman in white who's a medical student. This point about mid-staff was really interesting. I would never, ever support mid-staff. I think what I would say is that mid-staff is not unique. So up and down the country, there are pockets of bad care. And it's interesting to know what happens in those organisations that make it bad care. It's like what Christine said when she, you know, if you don't have the nurses and the doctors who support you, you can have a horrendous time in hospital. You know, you are at your most vulnerable, you are at your lowest ebb. I was in Chesterfield a couple of weeks ago and I was at a conference and a chap spoke there, and he was a gastroenterologist at Mid-Staff, who he eventually ended up being fired because of his he went and spoke to the GMC after Mid-Staff had happened, because of his continual kind of berating of the hospital. And he really viewed it, not in terms of just target-driven, but as a kind of dislocation of the doctors and the nursing profession from the public that they were meant to be serving. They no longer cared about their job. They were no longer interested in their job. They were deprofessionalised in their job. It wasn't a vocation. It was a waste. It was just, let's get through. I think, if you reduce doctors and nurses to just a consumerist interaction, you actually promote Mid-Staff-like behaviour as opposed to promoting professionalism.
Okay, Claire?
Thank you. I mean, the two are linked, the Mid-Staffs and the lady up there, because our response to every crisis, in inverted commas, and bear in mind these have been around since the time of the NHS, it's just we know more about them now because of social media and mass media. It's always been more regulation. Unlike, of course, journalists, where you can't even decide about Leveson, but it's always been more regulation. So now we have Chief Inspector of Primary Care, Chief Inspector of Hospitals. There will be CCTVs on every ward. There will be one on every corner of every ward. And the regulation, that is costing probably in the region of £1 billion, £1 billion a year. And yet the flip of that, the amount of public money being used to give nurses and doctors and all of us time to reflect in our practice and to do better stuff and to have the space to talk about the shit, because actually it is metaphorical and real shit that you have to deal with, it's probably about £1 million. So if you think about the mismatch, problems will always happen. If you've asked me what should we do, and it's a simple thing but it will never happen, we need to take the brakes off this clamping down of allowing professions to actually get on and start to make things right for their patients. It's just not happening, and instead the complete opposite. There is a culture of fear that permeates every single, I would say, I know this is on camera, more or less every single NHS institution at the moment. You cannot walk in or walk out. When I was a junior doctor, I used to be frightened of coming back on a Monday in case there was something had gone wrong over the weekend. Now I'm terrified if one of my patients so much as gets admitted to hospital because I might have made an error. And that's me as a very, very senior doctor who can fight my corner. If there's one thing I'd ask any of you to read, it's a book called Intelligent Kindness by John Ballard and Penelope Campling. And it sort of saved my life 2 years ago when I was in the midst of grappling with what was happening, which is the disintegration of everything I loved, which is my NHS. And it was in the midst of Mid-Staffs as well. And if it changed my life. It changed the way I looked. It talks about kinship, but you need to read it. And I would echo that you can read it. And I think we need to come somewhere between you two and find how we change the dialogue so it doesn't end up like a battle, because I think you're absolutely right, whoever said it's a battle, and we've picked up on that and we've played the battle out. Even to having, the patient rep, the doctor rep, the student rep. And maybe we should start having a proper discussion about what we want from our health service.
Okay, Hamish?
Yeah, well, picking up on that and Naomi's point, I mean, one of my sort of principles was to have a much better discussion both nationally and locally about what we're prepared to spend, how we do it, how we provide services. Because I think that's, in a way, how you develop a relationship and hopefully develop trust. It's about the gentleman here who said, I get this, doctors as a whole are lazy, greedy and all that, but my doctor's fantastic. That's because you have a relationship. Probably the reason you don't like the BMA is you don't have a relationship with them. Now, BMA policy, it's not decided by one or two high flyers in the BMA like me. It's decided by all the doctors, the majority of whom are members of the BMA. And then we've got this balance between, on one hand, should we ignore the causes of the ill health that we're seeing and get almost criticised by people like Christina for not doing enough about that, or are we being seen as being over-paternalistic and evangelistic when we tell people about their smoking, their drinking, their exercise, their other lifestyle choices? Now, I'm with Claire. I don't think it is primarily the role of doctors to deal with all the lifestyle choices, not because I don't think we shouldn't be involved in that, but I don't think we're the best people to do it. But equally, when we are seeing the results of that, we have to be involved in the decision making, whether it be in education, whether it be in the way big business and advertising runs, whether it be in the way transport's organised, whether it's things like smoking and alcohol, we need to be involved in that too. Malcolm Armott sort of says, if you're standing by a river seeing lots of people drowning, it's all very well going in there and pulling them out, but actually you should go a couple of miles upstream and seeing who it is that's pushing them in and do something about that. That would be a more logical thing to do. Lastly, on the sort of mid-staffs and failure, what you do about failure. I mean, obviously we need better mechanisms to stop failure, and nobody is going to defend the doctors and nurses in mid-staffs. There might have been some mitigating factors about understaffing and everything else, but they are not enough to condone the fact that people did not speak out. And it doesn't necessarily mean that you have to have privatisation or competition to have a decent failure regime. You basically have to find out that's failing and put in a team of people to sort it out. Now, whether they're a completely private team or whether they're a sort of team of government employees, I don't really care as long as they're effective at doing it, because the NHS is run by human beings. Human beings have failings and will fail, and therefore you've got to have mechanisms in place that first pick up the failure and then do something about it.
Okay, thank you. Christina?
I agree with that. I agree with what Claire said.
That's great.
But,
I agree with you.
I think, to go back to the mid-staffs thing, I think there is always, and by the way, congratulations on the work you did, I think there is always an element of personal responsibility and there is an element of cultural responsibility. And I think the truth is that most of us do what people around us do in most situations. You only have to look at those horrific experiments, I can't remember what they were called now, and the electric shock, what were they called again? The electric shock, when they turned up the electric, sorry? Yes, thank you very much. And everyone was happily, killing off everyone, but luckily there wasn't real electricity in the currents. Middle class people go to farmers market, people just do what people around them do most of the time. But obviously if you're, and on newspapers, I think it's very interesting, all this stuff about reputation and ethics. I was going off to the Learning Hospital at UCH to sit in on a day and interview lots of people, and it was 2 days after the Millie Dowler story broke. So obviously, nobody opened their mouth, and obviously I didn't have a story, and the photographer wasted their day, and I wasted their day, and it was all a bit of a disaster. But those journalists did what they did because they were also in a culture of paranoia and fear. They were being bullied by horrific editors. They were being asked to do things that were illegal a lot of the time, and similar things were happening in Mid Staffordshire and in every other ward and hospital and institution where these horrific things happen. I don't think the answer to them generally is greater regulation. I'm opposed to, I wrote a column in The Guardian this week, I think that the idea of hidden cameras in care homes is profoundly offensive to workers in care homes. I think that if you're doing work that is extremely badly paid and very demanding, the last thing you need is to be treated like a criminal. And, we should not be treating our health workers like criminals. And it's a very careful balance you have to strike, because obviously there wasn't enough surveillance at Mid Staffordshire, but these things do not, kindness and good care does not come about through surveillance. It comes about through good leaders, compassionate leaders, inspiring people to do their job well. To follow your point about staffing levels, I went to an event at the House of Commons the week before last about safer staffing levels on wards for nurses. I absolutely agree that there should be minimum staffing levels, and I think it makes that is not something that can be left to the discretion of a manager. And I absolutely agree that most bad behaviour comes about out of high levels of stress. So I know that I'm kind of, in some ways widely hated by nurses and so on. I felt I did what I did because I made a vow on my hospital bed to do what I could to make things better for patients. But I don't think that the punitive approach is right if you want to make things better.
I entirely agree the ethos of care is corroded by kind of turning the relationship between doctor and patient into a transaction, but it just seems a bit too simplistic because, essentially the relationship between GPs and their patients isn't a transaction. We don't have a full market in the NHS. People don't pay to go and see their GPs. You have a sort of pseudo market in the choice of provider system. So it seems that there's something else at work here in the kind of corrosion of that ethos, and I just want the panel to explore what that might be, because you talked about regulation, and regulation isn't necessarily about the market and about transaction. It kind of intrudes even when there isn't any market. So what's the role of regulation in this? And there also seems to be a wider loss of authority in experts, and a loss of belief in experts and scientific expertise and so on. So I think that I can see that as a political reason for saying marketisation is a problem, but it just seems to be a bit lazy and simplistic.
As the panel said, we got one of the cheapest healthcare system in the world, but also we got one of the slowest healthcare system. Do you think this is because the doctor actually have too much work to do, or is it because they're just taking their time? And do you think there's anything can be done by both patients or doctor to make our process faster?
There seems to be a consensus on the panel that we don't want to see the medical industry or medicine or the NHS controlled by market pressures, by marketisation. And we want to go back to a model where doctors were a source of authority who we could trust. We had a personal relationship with them, and they were people who were kind of almost beyond criticism in a way. So if the provision of medical services isn't going to be regulated by the market, as other services are forced to compete in order to provide a decent level of service. How would the panel like to see the provision of medical services regulated? Or do we just simply need to trust doctors to get on with things and view them as completely beyond criticism?
I've become chair of my GP's patient participation group, and I'd like advice from the panel as to how I can make a real difference as opposed to just being another part of the bureaucracy which weighs the practice down. Thank you.
3 very quick points. One, women. When I retired from The Guardian after 40 years watching you, 6 years ago, 66% of the people coming into medicine as doctors were women. Is that increased care or increased turnover? Second, managers. How are relations these days? Remember, it was Thatcher who actually introduced them for all this Tory criticism of managers. And after the report, which said, if Florence Nightingale was alive today, she'd be wandering through the corridors of St Thomas's with her lantern looking for who was in charge. And finally, Claire, about GPs. I mean, as a great supporter of you and the NHS, not to be today's story, front page on The Guardian, that 85% of GP practices don't open on a Saturday and still have pathetic hours in terms of for working people. How much?
Hard working, don't forget the hard.
Oh yeah, sorry, hard working. We've had hard working doctors.
No.
Anyway.
It seems there's a sort of structural underlying problem. A number of comments have been made about improving the relationship between doctors and the public, and I fully agree with that. But I think from the public's perspective, doctors, especially consultants that work in hospitals, a lot of time, money, investment is put into those individuals, maybe 10 years or so to become a consultant. And what can happen there is that there seems to me to be a blatant conflict of interest. A consultant works in the NHS, and all of us are aware of this. Then some of those patients get referred across to their private clinic. And it really seems to me that there needs to be a structural review of that basis of remuneration of consultants. And either, for example, consultants work wholly for the NHS or they work wholly privately. They don't use both the public funding of their own profession and then use the people that come to them through the public route as sort of a queue of people to treat on a private basis. So I don't feel that that's been really addressed. I think we need to, if we do that, then we can have that conversation with the public that says, and I fully agree with the comments there, that doctors aren't working on a basis of sort of liability minimisation, but actually value adding. So I'd like the panel to consider that sort of structural review, especially of consultants and their remuneration.
I work as a hospital doctor in a hospital that's under quite significant financial pressure, and I just really wanted to touch on the issue of management. I think it does potentially quite significantly impact on our practice, and we certainly as doctors feel under huge amounts of pressure. I just wonder what the panel thinks we can do in terms of improving that relationship and what the role of doctors as managers should be.
Okay.
A lot of questions.
Fantastic. I'm afraid you've only got 2 minutes to
We
deal with it.
would love to open 8 to 8, 365 days a year, but we have to pay for it. It's not just the GP, the nurses, the security guard, the admin. Okay? Full stop. And in fact, GPs still provide the majority of out-of-hours care, and as you see from my quote in the Today programme, if it's not us, it's the fairies. okay, through out-of-hours service. The second one, slowest. I don't know where you come from. I've just been to Shanghai to look at primary care there. The doctor there doesn't shut the door. It's like a supermarket queue, and basically you can all hear what's going on. The door is not shut other than for an intimate examination. So a patient is seen every minute. So I'm not sure we're going to get to that sort of stage. Of a minute consultation with no privacy. I think at the moment we have the most cost-effective health service. I'm not quite sure whether you mean slowest in all the other bits and pieces, but it's slow. PPG, very powerful. I'm going to be very simplistic here. Be kind to your practice. They are desperately trying to give you the service you need against a diminishing workforce, a diminishing income, making people redundant. Go to them and see how you can empower your patients to do self-management in some way, and just be kind to them, because they're all disintegrating. Commodification, I don't know who said it. Primary care is a market, is transaction costs. We are forced, we're paid according to a capitation, how many we see. So it is a transaction. We're paid, you've heard of QOF, we're paid against a performance-related pay, which is perverse. It didn't used to be, but it is. And you need to trust your doctor to do the right thing for you, not on whether it's going to save money for the state or earn money for them. And I'll leave you with one quote. In 2009, the amount of gaming, in other words, activity that was done that didn't need to be done in the United States was $300 billion. Okay? You need to trust your doctor to do the right thing for you, not because it's going to make more money, save more money.
Okay, thank you very much, Claire. Hamish, do you want to?
I think it was trillion.
Yeah, a couple of things. I mean, I didn't say cheapest, I did say most cost-effective. And I think you could make it faster if you had better rationalisation of the services. But, some of the things I was talking about, but that needs public support to do it, and political support too, because every time you talk about reducing a service at a hospital, there's an outcry. And if it's done for good medical reasons, then that can often be much better for patients. Women in medicine, the predominance of medical undergraduates are women. But I don't think it's just a feminisation problem. I think that there is a different sort of expectation of work-life balance too, and that's amongst men too. But it is resulting in more people working part-time. And that has a problem for continuity of care, and the fact that you can't always see the same doctor, because if you've got a lot of part-time people, it just follows. And the other problem is, if we do extend the working day to 12 hours, 7 days a week, then that will stretch it even further. People will be doing much more of the sort of shifts that they were talking about in the hospitals. So you'll have even less chance through the week of seeing, unless you very significantly increase the workforce. Or get nurses to do more, which we've been doing over the years too. I better pick up the point about consultants. There is an argument, and we've been through this countless times, for saying, you have NHS consultants and you have private ones. You then risk depriving the NHS of some very good people by having that separation. The system we have now, with quite a few checks and balances, mean that you have to do the private work in spare time. There are very strict rules about shifting people from waiting lists and jumping the queue by going privately. I'm not saying they're always rigidly adhered to. They should be. But I think before we do go down a road of complete separation, then you have to look at what you're going to lose by doing that in loss of expertise to the NHS. Management and doctors, it gets back to a partnership, and it's a partnership with the public, it's a partnership with patients, it's a partnership with managers. If it's seen as a partnership, it's fine. Too often, though, managers have been forced to look at the economic bottom line and ignore the care bottom line, and that's where the conflicts have arisen. And until we sort of sort out that conflict and dialogue, it's not going to work.
Okay. Frankie? Who wants to go?
Okay, well, I'm not going to respond to lots of individual points. I think I just really want to say that I think a very central issue here is about honesty. Honesty for what we can expect from the NHS. And it seems to me that any politician running for office now would have to run on a slogan that was something along the lines of, vote for me and your life will get worse at a slightly slower rate than if you vote for the other guy. Because the fact is that taxes in the Western world, the tax revenue is shrinking, the state is shrinking. This is a worldwide trend, and there are, you know, reductions in the West's power is shrinking and all the rest of it. So this has enormous implications. We can't keep funding the NHS. I think it's very hard to see how we can keep funding the NHS at the current rate when people don't want to pay higher taxes. So I think we do need to have a much more open discussion about that, and much clearer expectations of what patients can expect. But also, this is a really difficult one, and Hamish and I were talking about it beforehand, and I don't know what the answer is, but there is a whole issue about how we take responsibility for our own health, because it's great to have a health service which is free at the point of delivery, but does that mean we can stuff our faces, smoke ourselves to death, drink ourselves to death, and still expect to get bailed out in every single situation? The answer to that may well be yes, but then we have to pay for it.
Okay, thank you. And Frankie?
I'm going to talk very briefly about managers. I know some very good managers, I know some very bad managers. I think it depends on the manager. I mean, when I worked with Andy, we had a bed crisis. We're always in a bed crisis. I counted more managers on the floor than there were doctors. They asked me, what do I think that they should do? I said, go back to medical school. It didn't go down very well. You know, it depends on the manager. I think, you know, you've got to... You know, a hospital is only as good as the staff that works there. You get the service that you deserve in a way. The second point is about patient advocacy groups. I have a slight problem with patient advocacy groups and patient partnerships. And I have a real empathy for trying to make them not just a soundbite. My concern with self-management, although it does tie into Christine's point about taking personal responsibility, is, you know, if you're allocating chunks of time to, you know, I went to talk, they said we're going to give every one of our patients with chronic diseases 2 appointments a year to discuss their chronic disease. And I thought, well, what if you can't self-manage? What do I do with my patient, you know, the chronic alcoholics, the patients with poor social groups? Because the NHS is often picking up, you know, wider problems. If you look at geriatrics, you look at ageing, you know, we're trying to do too many things at too many times. The last point was on, I think, in a way we're suffering from a success in modern medicine. I think we've become disconnected from what it's like to be sick actually.
That's right.
And I was at college and there was somebody who said, oh, I work in Homeopaths Without Borders. And I thought, frickin' heck, if I was in Syria, the last person I'd want to see is homeopath. I'm going to save your life by giving you this, you know, water. And I thought, what a very bizarre, westernised approach to life. You know, look at it with MMR, look at it with anti-immunisation. When you have children dying of measles or have children, you know, being severely disabled by rubella, then actually the immunisation programme is a great success. And I think modern medicine is a victim of its own success, actually.
Okay, thanks a lot. Let's thank our panel.
Well, thank you.